Hi, everybody. My name is Avi Tenenbaum, and it's great to see everyone here at the conference. We're going to talk today about third wave CBT principles and concepts for mindfulness for the management of acute traumatic stress. So I've been working in the field of acute traumatic stress and disaster behavioral health for a number of years. I go around the world and train first responders, psychologists, social workers, psychiatrists, doctors, educators in how to deal with very traumatic events, but not in a post-traumatic way, but in an acute way. So something just happened, it's terrible, somebody just died, there was a mass shooting, there's an ongoing war, there's a hurricane, a baby didn't wake up in the morning. So whether it's helping a community or helping a family, this is something that I've been involved in for many years. And I give a 14-hour course on this, and you can find out more about that on my website, which you could find here below on psychotraumaunit.com. So aside from studying social work and addiction counseling and leadership, I'm also involved in the law enforcement community. And when I have free time, I involve myself voluntarily as a staff sergeant for the Israeli police and their operational units. And I go on emergency calls and I drive a police car. And when I have free time from that, I'm also an emergency medical technician or a medic. And the reason why I'm involved in the police and also in the emergency medical service system whenever I have time is because I feel that it's important to be able to talk about disaster experientially and not just as an academic type person who comes in with ideas, but somebody who has been in the field and sees trauma and feels trauma and sees how people show up to that, and to have those opportunities to lend a hand and to help people in the worst moments of their life. And so whether it's from an academic perspective, from a law enforcement perspective, or from a emergency medicine perspective, those are the places that I'd like to go and kind of observe and help people. So without any further ado, we're going to learn now for a short time. Very interesting idea. I've personally never heard anyone talk about this before. And I really wanted to share it with somebody, and I thought that this conference would be the perfect crowd to share it with. So please be my guests and welcome. We're going to talk about how principles from ACT therapy and mindfulness can be implemented into a psychological aid framework. So I'm going to explain what I mean in a moment. And to receive this presentation, by the way, in case you like it, write this down, psychotraumaunit.com. Just go to the contact page there and send me an email. I'm very happy to share my slides. I always share them, and I'm happy to share this one as well. Okay, so who cares about what trauma is? So it's a funny thing to say, right? Because we know that trauma is a debilitating, destructive, pervasive issue. It can become chronic. It can turn into chronic PTSD, and it can ruin people's lives. So let's just look at the top of this screen, and it says trauma event. So a trauma event happened, or we perceived that it happened. And I'm not going to get very deep into an introduction now on trauma. I do that in the bigger course that I give. You're welcome to take that course. But I'm assuming that everybody at the conference has a decent understanding of trauma. So we have a trauma event, a car accident happened, a terror attack, a baby that didn't wake up in the morning, a house that had an electrical fire. And what happens is people experience that event. So they develop some sort of reaction to trauma, either now or later, or they don't, but usually they do. And that's what we call trauma symptoms. And it's true that those symptoms generally go away. And that's what we call acute stress reaction or acute stress disorder. It's the acute traumatic stress that people have right after something terribly bad and traumatic happened, right? So we feel and think all sorts of things, or we don't, but we may soon in a few days. And then those trauma symptoms lead us to have social problems, emotional impairment, cognitive impairment. So I'm having thought rumination and intrusive thoughts. I can't stop thinking about things. I keep having that image or that sound of the person being shot in front of me. Everywhere I go, it follows me. I'm feeling emotionally extremely sad, depressed, numb, enraged, shocked, surreal. Socially, I'm not able to talk to anyone, or I feel like I can't be without anybody for a short time. Okay. And then what we do is, because we're feeling so bad and having a hard time, we adopt maladaptive solutions. So the most obvious ones are people will drink alcohol to deal with trauma. They'll use drugs, they'll smoke marijuana. And the problem with those solutions is that they always work in the short term and never work in the long term, and even create new problems. And let's not be so extreme. Think about even more subtle ways that people deal with traumatic stress. So we avoid going out of the house. We avoid going back to work. We use a ton of avoidance, emotional avoidance, or we'll do all sorts of intrapsychic, interesting solutions that never work, but we always, for some reason, keep doing them. So we'll keep thinking about something and being very, very cognitive about it and cerebral about it and thinking about it over and over and over, with this daydream that if we think about something enough, a solution will come and somehow something will change in our minds. So we really obsess about things. That's another type of solution. We want to gain a feeling of mastery or control over those thoughts. But that's also maladaptive, because then I can't live life because I'm busy thinking all day about my trauma. Or I can't leave my house, so I can't live life because I'm busy avoiding going out of the house to control my trauma. And then, of course, needless to say, we get into major life problems and dysfunction in multiple realms. So we start feeling as a husband, as a father, as a spouse, as a coworker, as a friend, in different social areas. We stop showing up to work and our work is piling up and up. The business starts to fall apart. Our family needs us, but we can't cook, we can't clean, we can't give people attention and talk to them and be part of what's going on. And everything starts to crumble all around us. And then that only gets worse because now we have our trauma symptoms and then our life is crumbling. And this leads to premature death, suicide, unemployment, divorce, post-traumatic stress disorder, addiction, and so on. And none of those are good. And usually we wind up with one or two or several of those outcomes, and it's just really not good. So obviously it's justified why we're talking about trauma, but not only about post-trauma, but about acute trauma. And that's what we're going to get into now. So what is psychological first aid? So again, we give a 14-hour course on that. We talk a lot about that there. This is just a taste. But it's really important, if you never studied about psychological first aid, to give a very brief introduction. What is psychological first aid? So it could be said that psychological first aid is the similar counterpart to physical first aid. So what's physical first aid? So we have doctors, surgeons, hospitals, and then we have ambulances with paramedics, EMTs. And so let's say a person falls off a ladder. They're trying to put an air conditioning into their house. And so they're standing on a ladder and they fall off the ladder. They land on their neck. They're not responsive, but they're breathing. Let's say that can happen, right? It's pretty bad. What do? You call for an ambulance. Well, what happens if the ambulance takes some time to come? It takes 10 minutes to come, an hour to come, depending on where you live in the world. So you try to help out and do something until the ambulance comes, right? You try to figure out what to do. Maybe on the phone, the dispatch center will say, don't move the patient. Check if he's breathing. Ask him these questions. Ask him where it hurts him, right? And they're trying to tell you on the phone maybe how to help him in the meanwhile until the ambulance comes. Eventually, the ambulance comes, the paramedics and the EMTs, they know how to assess the patient and very carefully move him onto a bed, onto a special gurney, and put him into the back of the ambulance and give him oxygen and give him painkillers and put him in a neck brace and do all the things that they're supposed to do to package him and transport him to the hospital. You come to the hospital, they receive this patient in the emergency room and they decide he needs emergency surgery. They take him to the trauma room, and I'm talking about physical trauma. They do surgery on him, and then hopefully he'll be okay, and he goes through rehabilitation, and the rest is history, right? So we give physical first aid in the very beginning of that story. First, we try to help out and do whatever we can, even though we have no formal medical training. And then the ambulance, they give some sort of professional first aid as well, right? They take some sort of a course. Sometimes they have an academic degree in emergency medicine as well. And they're trained in a more professional way to help, but they're still not a doctor, and they're still not a surgeon, and they don't have a hospital with them. And they're somewhat limited in what they can do. But for the meanwhile, until the person gets to professional help, we have these sort of people help out in the meanwhile. So psychological first aid is exactly that idea. It's something that we give to people because either they need professional help later on, but it's not available right now, or maybe it's not necessary right now, and we don't know if it's going to be needed until later on. And anybody can give it, and especially if you have formal training in it. So what is psychological first aid? Let's get into the details for a few minutes, and then we'll move on. Psychological first aid is a flexible intervention given immediately after a disaster. And when I say after a disaster, it could also be ongoing during an ongoing disaster, right? Let's say a war is unfolding, or a hurricane is happening for a few days, or there's a flood, and that scenario is happening for a few days. So you can give psychological first aid after an event, or even during an ongoing, prolonged traumatic event. The work is going to be a little bit different, but that's also in the realm of psychological first aid. So what are we trying to do when we give psychological first aid? We're trying to reduce acute traumatic stress. That's exactly what we're talking about today. That's what the conference is about. We're trying to reduce acute traumatic stress. Now, how do we do that? So I'm going to say this in a very general sense right now, and we'll get into the details soon. But we're looking to enhance safety and comfort, and that's referring to the Maslowian needs, right? The psychologist Abraham Maslow and his pyramid of needs. So during a disaster event, a person may not have food, they may not have family, they may not have clothing, they have no shelter. And so before anything else, we want to help a person with their very basic physical needs. So that's enhancing safety and comfort. And then we want to provide psychostabilization, which means maybe the person is hypo-aroused, they're under-aroused, they're very apathetic, they're almost subconscious in some sort of psychological comatose state, they're in a catatonic state, or they're very apathetic. When you talk to them, they're very, very slow, they're very confused, they don't know what to say. So that would be hypoarousal. And then you also have hyperarousal, which is a person who is overreacting. And we don't mean that they're overreacting emotionally, because that's an individual thing to do. But what we're talking about is on a physiological level, they are hyper aroused. So they're screaming and they can't stop. It seems like they're out of control, screaming 25 minutes straight. They're smashing their head in the wall. They're pulling their hair out. And these are all things that I've actually seen on many calls. So we step in there and we try to do psychostabilization and to bring the person to some sort of baseline level of arousal that they were at before this event happened, right? And once we bring them back to themselves, and once we bring them back to a baseline level of arousal, then they can already be in control and decide what they need to do next. So I'll just tell you a short story. Stories are really good for bringing out these ideas. So first I'll tell you a story about psychostabilization. There was a call here in the country where I live where a brother of mine was living about 20 minutes away from me in a different neighborhood. And he called me up on the phone one Saturday night and he said to me, Avi, there was a woman standing in the street screaming for 25 minutes straight. And that's where I got that number from. She's sitting in the middle of the street, screaming, 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 as if she completely lost control, as if she doesn't know her surroundings, and she can't and won't stop. Nobody knows what she wants or needs. No one can talk to her. Do you know if any sort of trauma events just happened here? Maybe you can send somebody from the emergency medical service. Maybe you can send somebody who does psychological first aid to come to this woman and help her out. So I look into it and I find out after 2 or 3 minutes of research that this neighborhood just had a very traumatic call that this woman was involved in. And what happened was people were walking down the street, it was late at night, and they found a person who was severely wounded, whose face was very, very injured and damaged. His airway was compromised, and he fell from some height. It seems like he fell or jumped from a high height, but they didn't know who he was. He couldn't talk, and where he fell from, who or where he belonged to. And so somebody called the emergency medical service, and an ambulance came and police came. And so the ambulance was busy dealing with the physical injuries and packaging this very injured patient and bringing him to the hospital as soon as possible, because that's what they do. They give physical first aid. And the police were knocking on the doors of this building, trying to understand, who is this person? They need to identify him. They need to tell his family that he got injured and to help the family get to the hospital and give information on where he was taken to. And they knock on door after door until they eventually, on the 3rd or 4th floor, come to a woman's house and they say, do you know somebody that is missing in your house? Somebody that just seems to have fallen or jumped from the porch, it seems, of your house. So the woman checks and it's her son. And it seems like she fell that the son who was sitting on the porch somehow fell down, or maybe jumped on purpose. Maybe it was a suicide attempt. Fell down from this porch several stories and landed on his face, which is obviously a very serious injury. And so she comes down and the police are trying to talk to her, and the ambulance left already, and she's just screaming and screaming and screaming. And this was her acute traumatic stress reaction to her son being missing, being wounded, being taken away. And nobody can reason with her, nobody can talk with her. And at some point, the police left her. Now, I don't know why the police left her. I don't know, what they did. I didn't know who the police were at that time, so I can't talk to them and ask them that question. But my brother, who lived in that neighborhood, said something is going on here. Somebody better help this woman because she's really stuck. And that's what I'm talking about, is when you're really stuck, when your mind is elsewhere, when you're traumatized to the point where you're gripped with fear, you are inundated, overwhelmed with tidal waves of utter helplessness, right? Because that's trauma. So anyhow, we sent somebody down there that knows psychological first aid that I trained, and they were able to get involved and help that woman and bring her back to herself, and then eventually help her get to the hospital be with her loved one. And then the story over there played out however it did. Okay, so that would be an example of getting in and helping somebody with psychostabilization. I'll give a second story because stories really bring out the point really well. A different occasion, it was a Friday night in my own neighborhood, and a medical call came out for a immigrant family from a country in Africa that moved to my neighborhood. And it seems like they lived in my country for a number of years. So they didn't just arrive, they were there for like maybe 10 years. And their son, who lived alone in my neighborhood, was not answering the phone. And you know those types of phone calls, medical calls, where somebody calls the police, somebody calls the emergency medical service because somebody's not answering the phone and we're worried about them. So it's called a wellness check, or in the country that I'm from, it's called chashash l'chayei adam, which means we are suspicious that somebody is not okay. All right, so the police come and the medics from the ambulance come, and I came as a medic at that time, and we're all trying to break into this person's house to get in and see if he's okay, because he's not answering the phone, he's not answering the door, he won't answer if you ring the doorbell. And a bunch of medics and policemen ended up breaking in through a second-story window, coming downstairs, and they found this young man, and he died 2 days earlier by suicide. He took his own life, and in a very interesting way, he basically went under a table, and he wrapped the table with very heavy plastic, and then he filled this chamber that he made with the plastic with gas, with natural gas, and so he breathed in the gas, and this is how he expired and passed away. So his family came not long after this happened, and they had to identify him and be told that their son died. And so the police told the father of the family that the son died. And the father started laughing uncontrollably. And this is a story I say often. If you take a course from me, you'll hear me say the story. He started laughing and laughing and laughing as if somebody told him the funniest joke he's ever heard. And this is another example of an acute traumatic stress reaction that people have. Because what's a joke? A joke is when something completely unexpected comes your way and you laugh. This is a way that people react to surprise. And so one way that people show up to acute stress reaction is they will laugh. So there are many very interesting acute traumatic stress reactions. And in my longer course, we talk about all the different ways people show up to trauma. But this was a really interesting one. And again, here the point was psychostabilization involved, taking the father, bringing him into the present moment, helping him become aware of what just happened, helping him be able to receive this information, feel and understand this information, come into the present moment, feel the gravity of that, feel the impact and weight of that, so that he can then be himself and he can then go and do whatever he has to do next. We don't want to make decisions for people, but if they need to be stabilized and brought back to themselves so they can make their own decisions, so then that's the step of psychostabilization. Now I'm going to say one story about enhancing safety and comfort, and then we're going to move on. So one time there was an arson fire, and it was 3 in the morning on a Thursday night. What happened was there was a hotel, and somebody was fired for doing not good work by his hotel. So he worked in a hotel, he was fired, and he was so enraged that he got fired that he took gasoline, and at 3 a.m. he went all around this hotel, poured gasoline, and set the hotel on fire. So 3 a.m. in the winter, people are sleeping, and all of a sudden the smoke alarm goes off and the sprinklers go on, and people start jumping out of windows and running down the fire escape and escaping from the fire. Unfortunately, several people were wounded from smoke inhalation. Some people were burned and wounded from fire. I think a person passed away in that story, but they called upon me to come as a person who gives psychological first aid to come and commandeer the scene and help bring other people who do psychological first aid to this major scene with many people who just experienced trauma, and to do some sort of a psychological triage, and to help each person get what they need and give them psychological first aid. Okay, so I show up there and it's 3:30 a.m. and I see a number of people who are naked out in the street on a winter night, freezing cold at 3:30 a.m. They have no clothing on, and they're wearing emergency blankets that the emergency medical technicians gave them. Every emergency medical technician has these foil blankets. They look like they're made out of aluminum paper, aluminum foil, and we use this to help people so that they don't get hypothermia, because sometimes we have to take off people's clothing and check their injuries and all sorts of things like this. So anyhow, these people were basically unclothed at 3:30 a.m. in the winter, and they were wrapped in these tinfoil blankets. So before you can talk to people and before you can give them psychological first aid, they are ashamed, naked and afraid. I think that's the name of a TV show. Naked and afraid, out in the street in front of tons of people, in front of news companies, news reporters want to talk to them, and they're sitting there without any clothing. So you have to help these people get shelter so that they're not cold, get them clothing. And this is where psychological first aid involves being really, really creative. So where do you get clothing for many people you never met before, who are all different sizes at 3:30 a.m.? Simple. There was a hospital nearby, and we asked if we can bring these people into an empty waiting room in the hospital until things get sorted out. We procured for them a room, and then we asked the hospital to lend these people hospital clothing because they have hospital gowns. So at least they got hospital clothing until we could figure out what to do with them. And so they had a private place to go. They were sheltered from the cold. They were sheltered from the news and from onlookers and bystanders, curiosity seekers. They had clothing. And once you do that, you can already then begin to do the rest of psychological first aid. And I'm going to read now the other steps. And that is helping people have coping skills from trauma, seeing what they need practically and helping them get that. So these people obviously needed shelter. They needed transportation. They had no money. They had no clothing. They had no place to go. So figuring all that out with them within reason. Psychoeducation. And psychoeducation involves teaching people information about coping skills and what they may feel, not what they will feel, but what they might feel in the days to come. So what they may feel in the days to come and how to deal with those feelings as that shows up for them, and increased survivor resources. So connecting them to further resources. And as you'll notice on all of the slides in this presentation, I bring sources for further reading. And if you get this presentation from me by going to psychotraumaunit.com, you can go look up all these papers and read them for further reading. Okay, so we spoke about what is psychological first aid. What is the rationale for this? Like, why don't we just show up and do psychoanalysis or psychodynamic therapy or classic CBT therapy or motivational interviewing or 1,000,001 different therapy models that we're used to doing in other cases? So number one is that immediately after a trauma event, there is no clear sign that predicts who is going to develop psychopathology. So what that means is we don't know who's going to develop psychological trauma that will stay with them and turn into PTSD. There are many studies about this. There's a lot of controversy about this. Does helping people with psychological first aid prevent PTSD? My opinion is that it doesn't have to. Meaning we don't need to make the argument that it does because it's right to do anyways. It's not clear that it does. I hope it does. Maybe it does, but it's not clear. Claims were made in the past that if people have what's called paratraumatic dissociation, which means that they are dissociated at the time of an emergency call, at the time of a traumatic event, this will show us that they're going to develop PTSD. It's not clear. These things are not clear. They're controversial. And most of the time, people anyways don't develop any symptoms at all after a tragedy. They're obviously in a deflated mood. They're sad. They're ruffled up. But that doesn't mean that they have to have very severe symptoms of trauma at the moment after something bad happened. And so you can't use their symptoms to guide treatment. You can't use their symptoms to make a goal now of symptom reduction and then tailor therapy to that. You also don't have 3 months or 2 years or 6 months to go and do therapy. You have 1 hour, sometimes half an hour, sometimes 10 minutes to help somebody. So that makes a lot of trauma treatments out the window, right? You want to do a trauma-focused CBT protocol. Yeah, but you don't have 12 sessions. You have an hour. You have 15 minutes. So you can't do that, right? So psychological first aid is meant to fit in a very short window and to take care of helping people when you don't have any symptoms to guide the treatment, okay? So that's rationale number one. Rationale number two is that after a large-scale disaster, there won't be enough therapists and mental health professionals trained in trauma treatment to help other people. And I want to say a nuance here, because in case people are listening to this and they make decisions on training their community in psychological first aid, I want to say when it comes to physical first aid, there's a big difference between a EMT or medic or paramedic who every single day, all the time, is involved in emergency medicine. So they don't have the highest level of training. They're not a doctor, but they have very much familiarity with emergency medicine because every day they go on the ambulance and they go to car accidents and they go to fires and they go to violence calls. And so they see a lot of things. They see people that broke their leg, people that cut their finger while making a salad. They get tremendous experience. They get people who have heart conditions, respiratory issues. And so they have very much familiarity with emergency medicine. Now, if you take a foot doctor who studied in medical school for many, many years, or a skin doctor, they have much more medical knowledge, but they have very little knowledge about emergency medicine. And so you can have the same thing with psychological treatment as well. You can have people who are incredible therapists, and maybe they specialize in depression treatment, OCD, all sorts of different conditions. Maybe they're a fantastic psychodynamic therapist. But the problem is they have very little familiarity with psychological first aid and disaster behavioral health. What does acute traumatic stress look like? What are the signs and symptoms of that? What is the trajectory of that? What are the ways that I can use to help people with that? What are the tools? So not only will there not be a lot of therapists, but even if you tell me, oh, we have hundreds of therapists, yeah, but you need therapists that know about psychological first aid. Otherwise, what happens is it's like you have a major building collapse and you have hundreds of foot doctors to give emergency medicine. And it's helpful, but it's not that helpful. So what I'm talking about is there's not going to be enough people familiar with psychological first aid and acute traumatic stress support and treatment, okay? So that's why we need psychological first aid and to train people and even therapists in psychological first aid, because these are things that therapists don't learn on their own. These are things that we don't learn in university and we don't usually know on our own. It's a specialty field of its own, just like anything else. Okay. The next rationale is that not everybody after a traumatic event will need trauma treatment, but that doesn't mean that they won't benefit from psychological first aid. You know, people are going through the worst moment of their life. The baby didn't wake up in the morning. A person got in a car accident and died, and nobody saw this coming. It's shocking. So they may not need trauma treatment. They may, yes, need trauma treatment. We don't know. But at the very least, they probably need a little bit of psychosocial support today because their baby just died and it's the worst moment of their life. And we wouldn't want them to be by themselves in the worst moments of their life. We'd probably want to help them out and support them and see what they need. And finally, it's the right thing to do. I wrote on the side, it's the right thing to do. It's the right moral decision to be there for one another as human beings, care for one another. I remember being at a trauma conference many years ago, and there was a woman, a very impressive, bright researcher, who she proved, in her opinion, that psychological first aid does not prevent post-traumatic stress disorder from developing. And therefore, she made a conclusion, which is a wrong conclusion, that therefore psychological first aid is not justified. And I said, my friend, we don't do psychological first aid because it will prevent PTSD. And therefore, since it won't, there's no justification for psychological first aid. The reason we give psychological first aid is because it's the right thing to do. And because just like if I saw a person, an elderly person, they're 84 years old and they fall down and they need somebody to help pick them up. And they don't need any medical treatment and they don't need rehabilitation. They don't need an ambulance. They don't need an emergency room. They just need somebody to pick them up. So I'll say, well, if you pick them up, that won't prevent them from falling again, or that won't, help them solve all their other problems in life. It's not connected. The person fell down. We want to pick them up because that's the right thing to do. When we would want somebody to pick us up as well. And so I said to this person, if your baby didn't wake up in the morning, would you put a sign under your door which says, please do not disturb us, because if you are friendly to me, it will not prevent PTSD. Have a nice day. You would want somebody to call you up. You would want somebody to see if you need anything. You would want your neighbor to care for you. You would want to tell your family. You would want some sort of support. So it's just apples and oranges. It's mixing two different topics. We can do things because it's the right thing to do, because somebody is having the worst day of their life and we want to be there for them, and we would want somebody to be there for us. And it may even prevent PTSD or may not, but that's not relevant. So psychological first aid is used in all sorts of calls, all sorts of trauma events, and primarily for single incident trauma events. Psychological first aid is not really used for, complex post-traumatic stress disorder type events where somebody, let's say, is abused in a domestic violence family where, they get beaten up by their spouse 100 times. Usually that's not where psychological first aid is spoken about. Psychological first aid is usually used in a case of single incident trauma. Single incident trauma. So here are some examples. Homicide. I just spoke to somebody last week, a paramedic who he did intubation and CPR on a man who was shot in the head. So that would be a case of homicide. Suicide, people who die by suicide. Mass shooting, right? So all the time in the United States, for example, but not only in the United States, we have terrorists and school shooters that come to school shootings. They come into shopping malls and shoot lots of people. So you have mass shootings, terror attacks, community violence between gangs, sexual violence, like somebody was just raped, and drowning. So drowning doesn't exactly belong on this list because there's no violent intent behind it, but I just ran out of room, so I put it there. When people drown, they drown in swimming pools, they drown in boating accidents, and they die. Even if they don't die, obviously this can be highly traumatic. I worked with somebody not long ago who their boat flipped over and they got stuck under the boat, and a string of their life jacket got stuck to the boat somehow, and they couldn't get out and come back on top of the boat. And it took them about half a minute to a minute until they, thank God, opened up their life jacket and swam back up to the surface. So interesting case, but obviously that was extremely traumatic for them. But that was a single incident trauma, right? We have fires, road accidents, industrial incidents with machinery, let's say, that hurt people, people that fall into a cement mixer, a machine that takes off their arm, serious injuries where people fall off their ladders while they're putting up their air conditioning, like we said, or they fall off a roof while they're putting something there, and things like this. Their finger gets taken off in a mixer while they're making food. Cardiac arrest, so people have heart attacks. Crib death, babies don't wake up in the morning. And then if you look on the right of the screen, we have larger scale events, right? So we have war, and we have natural disasters like a tornado, an earthquake, a mudslide, avalanche, and then we have man-made disasters. A man-made disaster might be biological warfare, or things like this, or a major event, like we said, a war, and so on, right? Or we have an MCI, which is a mass casualty event, like a bus, which overturns and it has 35 wounded and 4 killed. And so it's a major trauma event, which could have happened to one person, but it happens on a large scale, so it's a mass casualty event. So in all these cases, it would be perfect and called for to use psychological first aid. So psychological first aid is a modular approach, which means there are many different models and approaches for psychological first aid, but each one has models with steps, with parts, with modules to it. And so you would want to pick the parts that are relevant to the people in front of you, and you can skip other parts that are not relevant to the people in front of you. So if a person, for example, their baby didn't wake up in the morning, and they have their clothing on, and they have shelter, they have food and water, and they don't need any sort of safety and comfort needs, and they don't need psychostabilization, so we can skip those steps and go straight to the later steps of psychological first aid. We can see what practical assistance they need. We can give them coping skills. We can give them information on coping about future symptoms that may arise, and psychoeducation. We can connect them to further resources, okay? So we would go learn models of psychological first aid and then pick the parts, the modules, the pieces that are relevant to the people in front of us and skip the other steps, right? Another really unique thing about psychological first aid is that it can be given in a field setting. And so we can give psychological first aid in the middle of the street. We can give it in a bomb shelter while bombs are falling. We can virtually give psychological first aid anywhere. In fact, I'll say something really fascinating. When I was the director of a previous position that I had in Israel's psychotrauma unit and crisis response unit, I was the national director of that unit for a number of years. So one of the interesting things that a person before me who led the unit developed was the idea of bringing a pop-up tent to the side of a trauma incident, so that even if there's no private place to do psychological first aid, you pull out this little tent, it pops open, and all of a sudden you have a clinic. You take 2 little foldable chairs, you sit down, and now you can shield people from the bystanders and onlookers. It's not cold inside. You can focus with the person and you can talk with them in a way that they're not distracted and they're not seeing traumatic views. They're not seeing body parts or blood or sirens and lights and all sorts of very traumatic content. They're able to go inside and feel a sense of safety. And in that place, you can give psychological first aid. And so that was very, very creative. But the idea is that psychological first aid can be given virtually anywhere, at sea, at land, in the air, on the phone, which maybe we'll touch on later. It can be given telephonically on the phone. And it can even be given in writing. It can be given in video. And so it's very, very helpful, psychological first aid, and it can be given anywhere. The next thing is that psychological first aid can be given by people who are trained in psychological first aid. And so, a psychologist can take 7 years to train, 10 years to train. A social worker can take 5 years to train, 4 or 3 years to train. A person who is very proficient and good in psychological first aid, it can take a week to train. Of course, they need maintenance, they need continuing education, They need some supervision in order to be really, really good. And this is the type of thing that I do for a living at psychotraumaunit.com. I train people around the world in these things, but you can take anybody and train them in psychological first aid. So you can take teachers, you can take doctors, lawyers, bakers, tailors, you can take anybody that is a good candidate for knowing how to approach people in the right way. And they're good people, persons, and they're able to empathically understand people, and they're able to be respectful to people. And you can give them professional tools to know how to give psychological first aid. And when you do that and you train people in advance before trauma events happen, you've just made use of tremendous resources. Just like in COVID-19, people in the country that I lived in were trying to get the vaccine, but there weren't enough people to give the vaccine. So what did they do? They decided maybe they'll use veterinarians. Maybe they'll use emergency medical technicians and paramedics. Maybe they'll use nurses. Maybe they'll use all sorts of people that don't usually give vaccines. And by doing that and training people who have some sort of connection to medicine, there was enough people to give vaccines. So too, we can take people who have a connection to people that are good with other people. They know how to talk to them and to listen and to really bring them to a professional level of giving psychological first aid. And psychological first aid is tailored for particular disaster needs. And what that means is every single disaster has different needs that you may anticipate. So after an earthquake, probably a lot of people don't have a place to live. They don't have privacy. Their stuff might be getting stolen by other people, and they're worried about that. They don't have any belongings. They're worried about their loved ones. I remember a case of arson, another arson case, and this happened about 2 years ago, I think, where a man with pyromania, so he had a compulsive desire to set things on fire, pyromania. He took a book and ripped out the pages and lit the building on fire using these pages of the book. And he decided for no reason to impulsively set a building on fire. Also, it was about 4 a.m. and he just lit a building on fire. And at 4 a.m., people woke up, and this was a massive building with many families and many children, and people ran for their lives. They jumped out the windows, and other people sheltered in place, and the firefighters had to fight this huge, big fire. And thank God it was miraculous, but nobody was killed. Nobody was killed. Some people had smoke inhalation. There were some light injuries because people jumped out of windows and hurt their legs and things like this, but nobody was killed. And when I worked on that scene, so I ended up speaking to about 50 or 60 people from that fire in the week to come, giving psychological first aid. And most people had a very hard difficulty falling asleep. Because can you imagine when you're in the middle of sleeping and all of a sudden smoke detectors go off and there are loudspeakers and firefighters screaming through your windows, breaking down your doors, pulling you out of a fire? That's frightening, it's shocking, and it happened while you were sleeping. Now, in order to fall asleep, we allow ourselves to be relaxed and to feel good and to fall asleep, right? But now everyone was hyper vigilant, which is a symptom of trauma, anticipating there would be danger and a fire instead of letting themselves gently fall asleep. So how do people fall asleep if that's what happens when they're in the middle of sleeping, that fires happen? And especially when a pyromaniac made the fire, it's even worse. It wasn't just an electrical fire that happens to have happened because it was old equipment or something. It was a person with intent that walked up to their building and set it on fire for no reason. So it's a person with mental capacity and intent that set their building on fire, which makes it even more traumatic. Studies tell us that interpersonal interactions like this type, where somebody hurts somebody else on purpose, is even more frightening and traumatic. So in that case, most of the people I spoke to, men, women, children, had a very hard time falling asleep. And so one of the things that I tried to focus on was also speaking about how to work with sleep issues, and to fall asleep. Okay, so psychological first aid is not only given modularly for people's needs, but it's also tailored for the particular needs of a particular disaster. Here's another really important thing. Psychological first aid does not assume psychopathology. We don't assume that people are broken and that they have severe trauma and now they all need therapy, and if they don't get it, something bad is going to happen, and so on. Okay, I'm going to run along. Now that we spoke about psychological first aid, I want to make the main point that I think is really, really interesting, and that is psychological first aid, let's say, is a certain framework. It's a certain way of thinking, a certain set of professional beliefs, which is evidence informed, that we use to help people right after disaster and traumatic events. And I think that the beliefs that create psychological first aid and make it what it is allows us to integrate mindfulness and acceptance and commitment therapy components. And I'll show what I mean. Because psychological first aid does not assume psychopathology, and because they view acute traumatic stress as a normal reaction to an abnormal situation, this allows us to use ACT and mindfulness-based components in our work. Because in those models also, they have something that we'll see soon called destructive normality. Destructive normality. In other words, it is normal for people to feel hard and rough feelings, and thoughts and feelings are transient, they come and go. And when we try to control those feelings, that makes those feelings even more maladaptive. It makes our way of showing up to trauma even worse. And so that fits in really, really well with the way that psychological first aid views acute traumatic stress. Because we tell people in psychological first aid that what they're feeling or what they may feel in the days to come, at least for the next 3 or 4 days, it's really, really normal to feel frightened, shocked, angry, sad. You can't stop eating. You don't want to eat at all. You can't sleep at all. You can't stop sleeping. All those things and more, feeling numb, feeling guilt, feeling shame, all those things are very normal to feel right after a trauma event. It's so normal that it's not even in the DSM. And if I recall correctly, it's not even in the most current edition of the ICD-11, because it's not a psychological, pathological problem to feel trauma after a trauma event. It's a normal thing that normal people feel. Something bad happened, you feel bad for a few days, that makes sense, right? So we educate people that these feelings come and go, and that most of the time people are resilient, these feelings go away, people come back. And so this is compatible with the assumptions, let's say, of acceptance and commitment therapy and mindfulness, which we said it's normal for people to feel stuff. They feel depressed, they feel angry, they feel worried, they feel anxious, they feel vigilant. It makes sense. It's adaptive. It's normal. You're not broken for feeling these feelings. And the problem isn't that you're feeling those feelings, but that you're trying to control it, which then limits your behavioral repertoire, your behavioral choices. That's the problem. You're trying to control your feelings, and now you're so busy with that that you can't live life itself. And in ACT therapy, for example, the goal is not to reduce symptoms, but to live with vitality, to make choices that bring us happiness, joy, meaning, fulfillment, and to make value-based choices. And even if those choices bring more symptoms, we don't care, because we're not trying to reduce symptoms. We're trying to live a meaningful life, and that is the treatment and response to trauma. Okay? Acceptance and commitment therapy is one of my favorite models because it is also a transdiagnostic model, which means I learned many models in my life that they are fantastic and they're excellent, but for one particular issue. So you have special models for addiction, special models for depression, special models for marriage counseling. And that's fantastic for marriage counseling. And maybe if you only do marriage counseling and most of the time you have people without co-occurring problems and without dual diagnosis, so no problem, right? In disasters, and I think in most cases in any area of clinical psychology, people have several problems at once. People have anxiety, people have trauma, people have depression, people have marriage issues all at once, right? People have all sorts of things happening all at once. They have all sorts of trauma symptoms all at once. They have relational issues and a trauma symptom. This one causes that one. They work together. So you want a transdiagnostic approach, which uses the same principles to help for all types of issues that arise. So now it doesn't make a difference. It's a marriage issue. It's a trauma issue. It's depression. It's anger management. It makes no difference. We're going to use the same principles to help with all of the problems because we're attacking the issue on the level that we can come back to the metacognitive processes that help people deal with all sorts of thoughts and feelings in a more flexible way. So that's why I like ACT therapy. And that's why it's great for disaster work too, because when you have people who just lost a baby or their house just fell down in an earthquake and all their neighbors are missing and all their belongings are missing, they have many needs and many psychological difficulties. So you want to use something that addresses all of them. So ACT therapy is very different than a problem-specific approach, like we just said, that it only helps for a particular issue, or problems or approaches that aim to reduce symptoms, or approaches that are very existential and philosophical, because right now a person just lost their house. They can't think straight. They have so much on their head. They're so overwhelmed. You can't get too deep and philosophical with them right now. Their baby didn't wake up this morning. So you need something that's very simple and very direct, right? Or you have an approach which is great, but it takes a long time. It takes 3 years. Well, you don't have 3 years. You have half an hour. You have an hour, maybe 2. But you don't have 3 years. You don't have 2 sessions with them. You have 1 shot to help them, right? So those types of approaches may be great for psychotherapy, but not for disaster work. So here's just an example of one of my favorite models of psychological first aid. And as you'll see here, there are 8 steps or 8 modules, 8 components, and we will use different components for the different people in front of us as needed. And when will I use different mindfulness or ACT-based interventions? It will be during psychostabilization, during that module of psychological first aid, during the module where I'm trying to help a person come back to themselves into the here and now so that they're not hypo-aroused or hyper-aroused. I might use some sort of intervention to help them manage very strong feelings or to come back into the present moment. So I might use these ideas in those modules of psychological first aid. I might use these ideas in information on coping when I give the end in step 7 here of coping information and information on symptoms. I'm going to teach people what symptoms they may have in the future days, and I'll give them a technique or 2 on how to cope with them from ACT therapy and from mindfulness. And certainly when I come back from doing psychological first aid and I take care of myself and I'm doing self-care, or I'm helping out my friends who are with me, the fellow first responders or therapists who were exposed to trauma, we're going to use these ideas too, and they're great for self-care. So just some basic ideas in ACT. When people go through traumatic events, they use emotional avoidance or experiential avoidance. And the answer to that is we try to teach acceptance. People have what's called cognitive fusion, which means they get really stuck and entangled in different thoughts and beliefs. The world is not safe anymore. The fire might happen again tonight, or I'm stuck with a thought and an image of something I saw yesterday after a child was shot in a school. And so we have this very cognitive, sticky entanglement with different thoughts. And so we want to deliteralize thoughts in that way. And we want to do what matters instead of just fighting all the time with our symptoms and trying to control them and stopping to do what matters, right? So how do human beings suffer? That's what ACT therapy is all about. It's because they do emotional avoidance or experiential avoidance. It's because they have cognitive fusion with intrapsychic stimuli, and it's because they are not doing value-based living. And so again, just to run through this really quickly, and we're coming towards the end of this presentation, experiential avoidance, that's what people usually do after many mental health events or issues, and certainly after trauma. A person just saw a school shooting and they don't want to leave their house, and they don't want to let themselves go to sleep, and they don't want to do all sorts of things. They're avoiding engaging in certain people, places, and things because that is a trauma trigger for them, and they're avoiding trauma. So this causes more suffering, more pain, and more problems. So in the ACT model, acceptance and willingness is offered as an alternative to emotional avoidance. Can you be right here in this place with these trauma cues, with these triggers? Can you leave your house? Can you let yourself go to sleep and use acceptance and willingness and open yourself and be present to whatever is showing up here in order to have value-based living and do what you need to do to have a meaningful life? With cognitive fusion, so this is the idea that we get very stuck and entangled in traumatic thoughts. We re-experience thoughts. We get all tangled up in memories and in cues, and we take certain beliefs and thoughts very, very seriously and buy into those, which then limits our behavior. And then we're stuck fighting with these thoughts, or these thoughts are dictating our behavior all the time. And then our life becomes so narrow and so limited, and we can't live a meaningful life. And so the idea of cognitive diffusion, to diffuse from certain cognitions, is the deliteralization of thoughts, the deliteralization of feelings, memories, physical sensations, and those can be a powerful exercise for trauma survivors in many, many ways. And again, you can look up all these quotes, all these books, and I teach about these things at length in larger courses. And then, of course, when we're so busy fighting with our symptoms and struggling with the problem and drinking alcohol to deal with our trauma symptoms, or staying at home and no longer going outside and having fun with our friends, or speaking to people in our family and having social interactions, we get farther and farther away from what matters to us, and we create a living hell right where we are. We no longer are engaged in meaningful things. We no longer are engaged in our work. We are struggling all the time with boredom and with loneliness and with despair, and without social support and friends and hobbies and creativity and love and all the things that usually keep us a sense of vitality and purpose. So in ACT, the goal is not to reduce symptoms, but to drive people towards making decisions that will bring them a sense of meaning, a sense of purpose, even if they have trauma symptoms. And even if by going out of your house, your symptoms will feel worse, because when you have a sense of vitality and purpose, when you have meaning, that will help you to deal with trauma. So we're essentially teaching people to unhook and to disarm difficult thoughts and feelings, and to move towards things that matter, that make us feel better and help us. Okay, so we have all sorts of ACT interventions and mindfulness interventions that I'll teach people in a disaster scene after I've done many of the different parts of psychological first aid. But I'm looking for a very particular intervention to help a person to know how to show up to these very strong feelings in a more flexible way, to know how to deal with traumatic memories of the child being shot in front of my eyes yesterday in a better way, right? So these would be different examples. I'm not going to go into all these examples now, but you can get this presentation and look up these ideas. You know, one of my favorite things is Rumi's guest house, if you know that idea, teaching people that our body is like a guest house and we're like a hotel, and all sorts of guests, in other words, all sorts of feelings, all sorts of thoughts come and go, and we let them stay in our hotel as long as they want to. We let them come, we let them go. and we develop a flexible relationship with the trauma symptoms that we have. There's the idea of the Chinese finger trap metaphor, which is where when you put your fingers into a Chinese finger trap and you try to pull your finger out, you get stuck. But if you very, very gently stop struggling with getting your fingers out, but you approach the problem in a different way, then you're able to get your fingers out. And that's the idea that control is the problem, not the solution. There's an amazing act metaphor that you can look on YouTube called Demons on the Boat. It's silly, it's funny, and it's really interesting. And that's the idea that all sorts of trauma symptoms and anxiety, they bully us into listening to them and distance us from our values and from what matters to us. And if we can learn how to not take those threats and trauma symptoms so seriously, and we don't let them bully us, and instead we move towards what matters to us, we will live a life of vitality and purpose. The idea of the doom and gloom radio, a really cute act metaphor. In mindfulness, we teach people focused attention meditation, open monitoring meditation. So that's focusing on your breath for 5 minutes in a row, or, right, because that's focused, you're focused on one thing, or the idea of sitting for 5 minutes and just noticing anything that shows up for you. And the idea here is we're teaching people how to come into the present moment so that anytime a intrusive trauma thought pulls them away into the world of trauma, or anytime really strong, terrible feelings in their body show up because of trauma, they can come to their breath. They can come to the feelings of their feet on the floor. They can come to the sounds in the vicinity outside of them and notice the birds chirping and the cars driving by and so on. Okay, the idea of clean pain and dirty pain, dropping the anchor. I can go into each one. You can learn these all up on YouTube. I teach these in a larger course. But all these interventions, the point is they fit beautifully into psychological first aid. They don't clash at all with the beliefs that psychological first aid have about acute trauma, and it only complements the work, and it really fits well into a psychological first aid framework. The desired outcome of psychological first aid is reduced stress and increased adaptive functioning. Okay, so it's not symptom reduction, but it's to help people feel better in some way, to reduce their stress and to increase adaptive functioning. So the desired outcome of ACT therapy is psychological flexibility. It's also to be more adaptive, to be able to show up to anything that just happened in a better way. So to show up to the fact that the baby didn't wake up in the morning, to show up to the fact that there's a war, to show up to the fact that whatever the difficult thing is, and to be able to show up to that better, easier, and to show up to the traumatic thoughts, beliefs, core beliefs, physiological feelings, and emotions that come as part of trauma in a more adaptive, flexible way. So these ideas just go so well hand in hand. And I never heard anyone talk about it, how ACT therapy fits well into a PFA framework, and I'm very glad to have shared it with you. Now we're coming to the end. For free articles, trainings, free webinars, and more, please go to psychotraumaunit.com. Also, please check out on YouTube in the search box, Avi Tenenbaum PFA, and subscribe. We have a lot of things over there that we do all the time. Every time we have an event, we try to upload it so that there's a place where people can learn, even in many languages, Hebrew, English, Ukrainian, and many other languages that might appear there in the future. All sorts of interesting content about dealing with trauma on an acute psychological first aid level, and all sorts of videos on general well-being. Thank you, everybody, and it was a real honor to have met you today. Be well.